My name is Keith, and for those of you who are listening today, we have a very interesting topic to talk about. Now, I'm sure it's been a rough day already for everyone else that's recording videos because we have 1,000 different topics it feels like to go over. But today we have multiple different options through which we can provide the information to you. So, first of all, we have a brochure here. Now, if we were in person and not on a video, everyone would have one of these. But since we're here, we have just a general idea. It provides the how, what, and why about our topic today. And it provides some take-home information and some summaries on what to do in the future. Now, in addition to this pamphlet here, we have our board. Our board gives our topic. Our topic today is ventilator-associated pneumonia bundles. Now we have the different pieces of the bundle here, and I'll go through all of them. But taking a step back here, we'll go over to the PowerPoint, and we'll begin with talking about VAP and VAP bundles. And like I said, we'll go through each piece of the VAP bundle. Then we'll talk about our plan for the future and our goal on how we're going to implement this into the nursing setting, and basically where we're going to go from here. So, what is VAP? Now, VAP is a hospital-acquired infection, and it's far different than something you would just get, sitting in your own home and doing your own thing. No, VAP is something that you get when you're in the hospital. And worse than that, it is mechanical ventilation that actually causes the development of VAP, which is ventilator-associated pneumonia. How does mechanical ventilation cause VAP? Well, mechanical ventilation is a tube that they put down your throat to basically help you breathe when you can't breathe on your own. That tube breaks down the body's natural defense system and allows for bacteria over time to get down into the lower lobes of the lungs. Now, how is it different from regular pneumonia? Well, regular pneumonia is typically, like I said, something you get in the community. You don't get it in the hospital. So it's not really bacterially resistant. Whereas VAP can be very much so. In fact, it can resist much of the antibiotic capabilities that we have today, which can be very dangerous, making it difficult to treat for doctors to treat in the long run, because the bacterial resistance, we fight bacterial infections with antibiotics, and if we can't kill that bacterial infection with an antibiotic, then a lot of our cares are supportive. Now, odds are we'll eventually be able to find an antibiotic that does the job. However, VAP also is an infection in the lower lungs that drastically reduces the ability to get oxygen into your body. Now, how does it do that? It does that at the alveolar level, at the very capillary network, at the base of your lungs. It is where your lungs hook up to your blood supply in your body. It's where oxygen trades with carbon dioxide to get into your body and then transport down to the rest of your circulatory system to get oxygen to your cells. So VAP doesn't block all oxygen, but it reduces the amount of oxygen that can get to the rest of your body. Why is that a problem? Well, when you're in the intensive care setting, when you're under mechanical ventilation, you typically have a big problem with how much oxygen your body needs. Now, mechanical ventilation provides, high oxygen concentrations. It provides the ability for us to give that patient or you a very, very strong supply of oxygen. However, when you have something like this, it can decrease the ability for that strong supply of oxygen to get into your capillaries through your alveoli and to get down to the very basic circulatory system. So with the decreased oxygen capability or the decreased oxygen supply to the body, your body actually suffocates, and it can be very dangerous and very detrimental to the health of the individual. So why is VAP important? Well, statistically, 27% of patients under mechanical ventilation struggle with the diagnosis of VAP. That's 1 in 4 people that undergo mechanical ventilation in intensive care, in the intensive care setting, that struggle from the development of ventilator-associated pneumonia in their lungs. So, and the clinical presence of VAP, of course, it directly raises the mortality rates in intensive care patients, just because of, again, how it attacks the lungs and how it decreases the amount of oxygen that can actually get to the body. It also is, like I said, directly affects gas exchange, but it has a great increase to medical costs. Now, like, why is that the patient's concern? Well, a high medical cost directly translate into what the patient's paying for. Now, if he has great insurance, that's not necessarily something he has to worry about. But if he doesn't, he could be looking at bills in the hundreds of thousands of dollars for mere days of treatment. And that's something that he most likely will not be able to afford if he doesn't have health insurance. Now, and we're talking, by the way, increases of $40,000 and greater on top of what normally would happen at an intensive care setting, in an intensive care setting. So how do we take care of this? How do we reduce the development of VAP in intensive care patients? Well, tons of research has been done, studies have been created, clinical trials have been tested, and they've come up with something called a VAP bundle. A VAP bundle is basically a collective group of treatments that are used to then treat that patient. And it's very specific to VAP, but also the actual individual bundle pieces are common things that can also be used to treat other patients as well. Now, the first part of our bundle, our 5-part bundle, there's many bundles, many different bundles that have been studied, and there's a large range and number of different interventions, different treatments that can be used for ventilator patients to help reduce this development of VAP. But the first piece here we see is raising the head of the bed. Now, raising the head of bed, you think, oh, so I just lift, I have hospital bed, I click the button, the head goes up, that's it, right? How does that affect something so strong and so crippling as ventilator-associated pneumonia? Well, raising the head of bed under studies has shown that it prevents the ability for the bacteria to get down into the lungs. When you're laying flat, it's easier for bacteria to travel from the oropharynx down into the lungs and infect the lung tissue, causing the pneumonia. Another reason why it's included in the bundle is because it's really low cost. And we've already paid for the bed 700 times over with how many patients have been in that bed. And all you have to do is hit the button to make the bed go from flat to 45 degrees. Which is, it's incredibly low cost. It's low risk to the patient. The patient typically doesn't have a problem with sitting at a 45-degree angle. Well, we'll switch over here and we'll say that the reduction of 25% in VAP cases. So that means that this piece of the bundle, along with other bundle interventions, have shown a 25% decrease in VAP cases, which is quite significant. Now, there are some things that would prevent a patient from being able to be put at 45 degrees. For instance, let's say someone breaks their back. Well, if they have a broken back, a lot of times the recommended degree for which they lay is no greater than 20 degrees with their brace on, or with their brace off, rather. So how do we hit that happy medium where we fit into we want it as high as possible for VAP, but also it has to be low for things like spinal injuries. Well, that's a discussion that the doctor will have with the nursing staff and with the residents to determine what is the best angle that we can have the patient at so that they will not develop VAP, but also not really have any complications from their spinal injury. So the next piece to our 5-part VAP bundle is something called chlorhexidine oral care. Now, this is just like typical oral care, except for they use a 2% or so chlorhexidine solution on the swabs to then swab the mouth. The thing about this is that it's very simple to do. It's just, I mean, it's like a little bit harder than raising the bed, you know, but on the grand scheme of things, all it is a swab. You swab through their mouth. And it's simple. The solution itself, chlorhexidine, is an antibacterial solution that is designed to clean the oral cavity and reduce the amount of bacterial colonization, the amount of bacteria that grows in the mouth. So, and if you think about it, you have a tube going through your mouth, down your airway, and into your lungs. So how do we reduce bacteria from getting from your mouth down into your lungs? Well, we use a solution to help reduce the amount of bacteria that actually grows in your mouth. And there is a lot of bacteria that grows in your mouth. So this helps with that. Another thing too is doctors have theorized that prophylactic antibiotics, in other words, antibiotics that are used not because there's a present infection, but because one could develop, could fulfill this part of the bundle. Now, the problem with that is too much antibiotic use actually creates resistance antibiotics. That's why in the hospital you have something called resistant infections. The resistant infections are developed because in the hospital lots of antibiotics are used. These bacteria, this bacteria develops a resistance to the normal antibiotics that we have and can become really incredibly strong, like things like MRSA or MRSA or VRSA or VRSA are these type are bacteria that can resist some of the very strong antibiotics we have. So we use something like this that really doesn't develop a bacterial resistance to it, so it can safely reduce the amount of bacteria that is colonized in the mouth. And additionally, it has shown by itself to reduce VAP by around 6%, from about 31% to about 25% in clinical trials, which is really incredible. And because it's so simple, all it is many times in the intensive care units, they have them just hanging right on the IV poles. So you just grab the little container that has the swab in it or has the solution in it, you grab a swab, and you go through the mouth, and that's it. So the next piece. Now this piece is something that almost everyone in the hospital has something to do with this piece. This is blood clot prevention. Blood clot prevention is probably the single most widely used thing I've ever seen in my experience of practicing in a hospital. And that is usually accomplished through medications or things like passive range of motion to get the body moving so that blood does not stop in one area of the circulatory system and then begin to clot. The problem in how this connects to the VAP and the VAP bundles is the development of something called a PE. A PE is a pulmonary embolism. In other words, a blood clot that has mobilized or moved from its original location and is traveling towards the lungs. Now, it doesn't really hit the lungs unless it develops in the legs. So a lot of PEs develop in the legs and they travel from the legs to the lungs. Now, if they are in the heart, they go to the brain, and that's when you have stroke. But in this case, we're worried more about the legs going to the lungs. Our lungs, of course, are incapable of supporting our body currently in the state that we are in because we're on a ventilator. That's what ventilators are for. And we need to prevent any further respiratory distress, any further damage or lack of function, to use the term right. Basically, we want to make sure that our lungs are working as best as they can. Now, that is something that we can do lots of things for, and this might still happen. However, one intervention anyways to do this blood clot, or to prevent the blood clots, like I said, is medications. And additionally, like I said with VAP inhibits gas exchange at the alveolar level. Well, this does the same thing, but in a little bit different way. So if you have a big blood clot flowing through your veins and it ends up in the lungs, you actually block any blood flow from passing through that clot. So there no longer is blood flow on the circulatory end to the lungs. Therefore, oxygen distal or beyond that blood clot, oxygen cannot exchange and flow properly into the body. So it's from a different perspective, from the circulatory instead of from the alveolar level, but it can be very damaging if it's not prevented properly. Now, gastric ulcer prophylaxis, or just a fancy word for gastric ulcer prevention, or stomach ulcer, is this piece of the bundle. This piece of the bundle is a little out there at first. You think, how does my stomach transfer into the lungs? How is there a correlation between that? Well, the correlation comes when you understand that mechanical ventilation is a very high stress situation. It has many issues that further increase the stress level in the body. Well, stress is the #1 cause of a gastric ulcer. And gastric ulcers are problematic for a number of ways, but the main thing would be a bleed that we don't want to have happen in a patient who has already got a lot going on with them. So we have to look at it from a different perspective because we're trying to protect our lungs as much as possible. So we can't have something that neutralizes the acid in the stomach. We have to have something that protects the stomach without reducing the acidity of the stomach. Why is that a big deal? Well, the acidity kills the bacteria that's in the stomach. And if you reduce the acidity, then you have an overgrowth of bacterial colonization, which then can go up through the esophagus and then back down your airway into the lung tissue, which causes really a great issue, and it's a great cause of ventilator-associated pneumonia. Now, like I said, we have to reduce that acidity, or not reduce the acidity. We have to maintain the acidity, protect the stomach, in order to help bacteria not get to the lungs. Now, this last one is really important, and it's sedation holidays. Now, it sounds weird at first. You're like, why do I need a sedation holiday? Well, people who are mechanically ventilated typically have basically a moderate level of sedation that always happens. They're always sedated with some kind of medication. I have propofol listed here. That's just one of the medications. There's plenty of medications that are used on a drip to help maintain the patient in a sedated state. And if you think about it, you're lying in a bed, you've got tubes and wires coming out of you everywhere, and you have a tube down your throat. I probably want to be sedated a little bit too. I mean, like, I don't want to be there and have all of this going on and I have to stay still on my own. Whereas this sedation comes in and really relaxes the patient, reduces that stress level, reduces the anxiety of the patient, and helps them remain relaxed, as lack for better words. But sedation holidays actually is where you interrupt that amount of sedation that they have so that they just wake up a little bit. Now, it's not all the time. They obviously wouldn't have you off sedation for a long time. They'd put you back on, but the reason you have sedation is that you basically would then have a holiday to help with different assessments and such to decrease the incidence of VAP. Now, the plan going forward would be to reduce or to actually talk to the Institutional Review Board and try to get this VAP bundle implemented into the workplace within 1 year, and hopefully see results from that. Now, there's many different resources available for nurses all around, but overall, VAP is a very, very detrimental thing that we need to eliminate as much as possible because it can be very deadly for intensive care patients.